Adhesive capsulitis, frozen shoulder, shoulder and elbow, orthobullets. Adhesive capsulitis, commonly known as frozen shoulder, is a condition where one experiences a loss of both passive and active shoulder movement. It's frequently linked with conditions such as diabetes and thyroid disease, yet its underlying cause remains unclear. Diagnosing frozen shoulder involves clinical evaluation, noting a significant reduction in shoulder motion. Both active and passive movements are restricted, making it a noticeable condition for healthcare providers. Treatment usually involves an extensive regimen of aggressive physical therapy. If underlying diseases like diabetes or thyroid disorders are present, they require medical management. In severe cases, surgical interventions might be necessary. This condition is more prevalent in women, particularly those aged between 40 and 60 years. The demographic information helps in identifying and assessing risk factors associated with adhesive capsulitis. The mechanism of injury can be primary or idiopathic, emerging without a clear cause. It can also follow trauma, such as a fracture, or post-surgical procedures, like rotator cuff repairs. Pathoanatomically, frozen shoulder involves an inflammatory process, leading to thickening and fibrosis of the joint capsule. This results in the capsule adhering to itself and the humerus, creating a mechanical block to motion. Fibroblasts and myofibroblasts with abundant type 3 collagen contribute to the condition. The coracohumeral ligament and rotator interval capsule are particularly affected, playing a central role in motion restriction. Associated conditions include diabetes, which often presents stiffness as an initial symptom. Patients with longer diabetes duration or autonomic neuropathy face worse outcomes despite treatment. Other related conditions encompass thyroid disorders, Dupuytren's disease, atherosclerotic disease, and cervical disc disease. These associations highlight the systemic nature of adhesive capsulitis. The shoulder's capsuloligamentus structures provide stability to the glenohumeral joint. In their healthy state, they act as restraints at motion extremes, an important consideration in adhesive capsulitis. These structures include the superior, middle, and inferior glenohumeral ligaments, with the latter consisting of anterior and posterior bands and the axillary fold. Their involvement is crucial in the pathology of frozen shoulder. The rotator interval, a triangular area between specific muscles, contains key ligaments like the SGHL and coracohumeral ligament. This region is significantly involved in adhesive capsulitis. Clinically, frozen shoulder progresses through stages: freezing with pain over months, frozen with reduced motion affecting daily living, and thawing, where motion gradually returns over an extended period. Arthroscopically, stages include patchy synovitis, capsular contraction with adhesions, and increasing contraction, illustrating the progressive nature of the condition and the challenges in managing it.